Welcome to All Things Celiac, our first webinar of 2021, hosted by the Celiac Center at Harvard Medical School and the National Celiac Association. I hope all of you have weathered the holidays as we continue to maintain social distancing. Not an easy thing. I'm Lee Graham, Executive Director of the National Celiac Association and founded in 1993. The launch of Feeding Gluten-Free, the initiative in April, is in response to the need for food pantries, which has exceeded our expectations in how badly they need food, particularly gluten-free. Up to now, we have been able to ship $400,000 of gluten-free food to food pantries in 28 states. And even so, the need continues. Food pantries tell us that the demand is 2 to 3 times more for gluten-free families than ever before. I hope you can help us with helping these needy children, adults, and seniors by donating on our website, nationalceliac.org. Thank you. For today, you are welcome to ask general questions through the Q&A feature, which is located on the bottom right corner of your Zoom screen. If you are still struggling to connect, tech support is available at digitalmedia@partners.org. That's digitalmedia@partners.org, or phone 857-282-6470. Also, this session is being recorded and will be available for viewing on NCA's website, nationalceliac.org. I'm excited to introduce today's moderator, Dr. Daniel Leffler. Dr. Leffler is a practicing gastroenterologist caring for patients with gluten-related disorders, including celiac disease and other gastrointestinal disorders. He is a founding member of the Celiac Center at Beth Israel Deaconess Medical Center, an associate professor of medicine at Harvard Medical School. He has received multiple grants from National Institutes of Health, numerous foundations, and industry members supporting his research to advance digestive health. He has authored or co-authored more than 150 articles in peer-reviewed literature and co-authored a patient-focused book with Melinda Dennis titled Real Life with Celiac Disease, Troubleshooting and Thriving Gluten-Free. He joined Takeda Pharmaceuticals in 2016, where he is a senior medical director and global clinician leader for celiac disease in the gastrointestinal therapeutic area. Please welcome Dr. Leffler.
Thank you so much, Lee. And thank you to the NCA for setting up this talk. I know it's going to be an incredibly exciting webinar. Thank you everyone for joining from your homes, wherever you are. I just want to remind everyone that they will have 2 talks followed by a Q&A session. This will be recorded, as Lee mentioned, so you'll be able to watch this again, share it with others. Please go ahead and do that. If we did get some questions ahead of time, we have a lot of excellent questions, but if there's things that come up from the speakers or questions you have, please put them in the chat box. We'll be following throughout in the Q&A area. Please keep your questions as general as possible so that they are applicable to as many people as possible who are watching the webinar. So without further ado, it's my great pleasure to introduce Dr. Edwin Liu. Ed, I've had the opportunity to work with Ed over the years, and he's one of my personal go-tos whenever I need help with celiac disease as a clinical condition or interpreting the research. Ed is a professor of pediatrics at Children's Hospital Colorado and the University of Colorado School of Medicine. He's a pediatric gastroenterologist and completed his gastroenterology training at Children's Hospital Colorado back in 2003. He is the Taplin Endowed Chair for Celiac Disease and the director of the Colorado Center for Celiac Disease at Children's Hospital Colorado. He has completed his initial research in the lab of George Eisenbarth, a seminal leader in immunology, and has worked with the Barbara Davis Center for Diabetes at the University of Colorado School of Medicine, working on vaccine therapy with insulin peptides to prevent diabetes in mice. More recently, Dr. Liu has been a collaborator in the multinational TEDdy study, it's short for the Environmental Determinants of Diabetes in the Young, which also looked at celiac disease. and worked across several countries. He's also involved in a really exciting Colorado mass screening study, the ASK Autoimmune Screening Study for Kids, to test the long-term feasibility and outcomes associated with screening for celiac disease in pediatric populations. So thank you, Ed, for joining us. We really look forward to your talk. And I believe we're going to start with a polling question. So the polling question is this, and please feel free to jump in and put your responses down. Besides a gluten-free diet and celiac disease, what are you doing to try to prevent other autoimmunity from developing? 1, additional dietary changes. 2, taking vitamins or other nutritional supplements. 3, other types of behavioral or lifestyle changes. Or more than one of the above things, or nothing at all. Nice spread of answers. Dr. Liu, take it away.
Okay, thank you so much for that, Dan. Really happy to be here. Let me share my screen with you all. So yeah, I really appreciate the opportunity to come here and speak with you. We're going to talk about, whether or not is the autoimmune drive on autopilot in celiac disease autoimmunity. Okay, that's enough autos here. So relevant disclosures here, but I'll also add that the topic of autoimmunity and celiac disease is extremely complicated. And so, prepare to be disappointed if you're looking for all the answers to your questions. I'm going to do my best. Sincerely, I really want to try to make sure that we all understand why I think there's such a co-occurrence of autoimmune diseases with celiac disease. But at some point, I'll probably have to make things up because I don't know everything. And if you keep asking me questions, that's what's going to happen. So the objectives here are to really understand the types of autoimmune diseases that are associated with celiac disease and why we think they co-occur, discuss the recommended monitoring for autoimmunity or lack thereof, and explore the role of gluten in the development of autoimmunity and is there? So yes, autoimmune diseases in general are on the rise. It's not just for things like type 1 diabetes and celiac disease and multiple sclerosis, but it's also for other immune-mediated diseases like Crohn's disease and asthma. And we don't really know why. I mean, the TEDdy study that Dan had mentioned is really looking at the environmental triggers for these kinds of things, what's going on in the environment. But we certainly feel that the changes in the environment are probably playing a huge role in this, right? And I always like to kind of talk about the hygiene hypothesis for this work, and just to put it in a very simplified way, it's sort of our environments are becoming so clean that our immune systems don't have a whole lot to do other than cause trouble at this point. And so that might be a reason why we're seeing a lot more autoimmune disease, but it's putting it in a very simplified way. And we know that there's many autoimmune diseases that are reported to be seen with celiac disease. This is just one list, right? And there's a lot more, and a lot of them are more anecdotal. Okay, but the thing to keep in mind is the risk for these things aren't all equal. Okay, and in fact, when you look at this list, it's sort of the direction of autoimmunity diagnosis really seems the way heavier going in one direction. Okay, all the literature that's been published, vast majority talk about you've got one autoimmune disease and what the chances you're going to find celiac disease in addition to that. Okay, and so it's usually going that direction, looking for celiac disease with screening with the tissue transglutaminase autoantibody, for example. But we have very few papers that look at the development of autoimmune diseases after someone's been diagnosed with celiac disease. And that's what I've really been interested in. I'm really trying to find some information on well, how often should we be worried about another autoimmune disease once you have celiac disease? And bottom line is, as far as I know, it's just less. So what's actually being done clinically? Well, this is according to the NASP again. That's the North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition. Okay, their clinical report. So on the left side, these are the autoimmune conditions that should trigger screening for celiac disease when you have it. If you have type 1 diabetes, if you have autoimmune thyroid disease or autoimmune liver disease or juvenile chronic, juvenile idiopathic arthritis, this is when you should be screening for celiac disease. Okay. Now, on the other hand, when someone has celiac disease, these are the autoimmune conditions that they say you should be screening for when you have celiac disease. Okay, and it's not much, right? I mean, basically, you know, NASPGHAN recommends that you check the liver chemistries at diagnosis, looking for a celiac hepatitis or like an autoimmune hepatitis. But then otherwise, the only recommendation is really to screen for autoimmune thyroid disease periodically. So despite all this discussion and concern, I mean, even looking at the polls, I mean, the reason why I asked about the polls is because I want to know, like, how worried are people about the secondary development of autoimmunity? And it sounds like, you know, half the folks, I mean, maybe more, are enough to be able to actually change a behavior, right? And so I think this is really relevant for us to really understand what the risks are. And we just don't have enough information about this yet, but hopefully I can put this in perspective for you. So some key questions, I think, are like, does celiac disease directly lead to other types of autoimmune diseases? And can a clinical course of autoimmunity be changed if someone's diagnosed with celiac disease? So some immediate key points here, just to go on, would be that individuals with celiac disease certainly demonstrate concurrent autoimmune diseases more frequently than individuals without celiac, right? And it's been estimated that 30% of adults with celiac will have an additional autoimmune disease, which is like 2 to 3 times higher than controls. And we know that screening for celiac disease in patients who have an autoimmune disease is oftentimes encouraged or even recommended, okay? But again, the other way around, screening for autoimmune diseases in someone with existing celiac has been essentially limited to just autoimmune thyroid disease. Now, we also know that there's an extensive genetic overlap that can exist between celiac disease and other autoimmune diseases, and this is what we're going to talk about next, okay? So looking at like the genetic risk in autoimmunity, I think when you talk about this, you always need to start with the HLA, okay? The HLA region, that's like DQ2 and DQ8, okay, for celiac disease. But for most autoimmune diseases, this is the strongest association that you're going to see, okay? And again, celiac disease, what we call it DR3 DQ2, okay, and DR4 DQ8 is the biggest one. And celiac is rather unique because it's very, very HLA restricted, meaning like 99%, you know, of folks with celiac disease are going to have either DR3 DQ2 or DR4 DQ8, okay? And if you don't have it, then you're practically not going to have celiac disease. And you know, the impact of the HLA is very, very high in celiac disease. But then also something like type 1 diabetes. Type 1 diabetes is very dependent on DR4 DQ8 and lesser for DR3 DQ2, okay? Autoimmune thyroid disease also has a higher risk of having DR3 or DR4, okay? Autoimmune hepatitis, same thing. You know, you tend to have more DR3 and DR4 in people with autoimmune hepatitis. Rheumatoid arthritis tends to lean more towards DR4, but also this other one called DR1. And lupus has a bit of a predisposition also to DR3 and also this DR15. Now, certainly up here, celiac disease is the most HLA restricted one, followed by diabetes, and everything else, that the contribution of HLA becomes less and less, but there certainly is an association. It's interesting because multiple sclerosis is certainly predisposed if you have DR15, but in some countries, DR3 increases your risk of MS. And note that like this DR15, DQB10602, this MS gene is also linked to narcolepsy, and it happens to be protective for type 1 diabetes. So when you try to look at this, so this was adapted from this paper looking at autoimmunity in Latin America, but you're looking at like shared HLA-DRD2 molecules from 6 autoimmune diseases, and then I added celiac disease to this. You can see how much is actually shared, right, with the big genes like DR3, DR4. So celiac disease for DR3 shares DR3 with Sjogren's syndrome, lupus, type 1 diabetes, autoimmune hepatitis. And then DR4 is shared strongly with type 1 diabetes, autoimmune hepatitis, and rheumatoid arthritis. Again, so there's a lot of like a lot of shared HLAs. And then again, when you look at the relationship between multiple sclerosis, for example, in type 1 diabetes, it's the DR15 is a bigger risk for MS when you have multiple sclerosis, but yet that same gene kind of protects you from diabetes. And same with this DQB10603, where it's more of a risk for like autoimmune hepatitis and more protective for diabetes. So this is certainly not comprehensive, but just so you can understand visually like how interrelated these things are. And this is a hint as to why they co-occur oftentimes. Thing is, it's not just the HLA, right? I mean, there's like 60 other genetic risk variants, or what I call like just smaller genes in celiac disease that also increase your risk, okay? And this is known because of like this GWAS studies, which stands for Genome-Wide Association Studies, all right? And they found that like most associated gene loci that kind of increase your risk for celiac disease are fairly common, okay? And they only confer just a modest increase in celiac risk. So the median odds ratio here is 1.17, okay? If it was 1, then that means there's no relationship, there's no increase in risk, okay? So it's 1.17, and compare that to like the HLA region for celiac disease, which is 6, okay? And you see how much more HLA plays a role compared to like all these other small genes. Now, of course, when you start combining more and more of these genes together, if someone happens to inherit a lot more of these autoimmune predisposing genes, then yeah, it does sort of bump your risk up a little bit more. And keep in mind that most associated disease loci are shared with other autoimmune diseases, right? So for celiac disease, at least one locus is shared with at least like with 13 other immune-mediated diseases, okay? And remember, like sometimes a variant on one gene may confer risk to one particular autoimmune disease, but it may be more protective for another. I hope this is clear to you guys. I'm trying to make this as simple as possible. But like here's a visual representation from 2012, just kind of showing like how all these other small genes can be shared too. Just like HLA can be shared, these other genes are shared, okay, with celiac disease, rheumatoid arthritis, lupus, MS, type 1 diabetes. So we're going to move away from genes now and just kind of look at like, okay, how about does a late diagnosis of celiac disease actually drive the co-occurrence of additional autoimmunity, okay? And so the data is really mixed here, right? So early studies suggested that like the prevalence of autoimmune disorders in pediatric celiac disease really depended on the duration of gluten exposure, okay? Meaning, and they thought it was really related to like the age of diagnosis. So if you're diagnosed really late, that means you had more time to be cumulatively accumulating gluten exposure, and that would increase your risk. But then follow-up studies kind of looked and thought like, well, the older age of diagnosis certainly is associated with more autoimmunity in adults, but when you actually looked at the duration of gluten exposure, it wasn't. And then like a more recent study with 2005, they found that the development of other autoimmunity wasn't associated with the duration of gluten exposure. So it kind of goes in both directions, right? And I think the bottom line here is that when you're asking the question, does a late diagnosis or a delayed diagnosis of celiac disease drive the co-occurrence of additional autoimmunity? I think, well, the data is mixed, but the overall answer, I think, is no. And it's certainly not enough for us to justify screening kids to diagnose celiac disease earlier in order to try to prevent further autoimmunity. What about the gluten-free diet, though? I mean, does a gluten-free diet for celiac disease also improve, like, let's say, autoimmune thyroid disease? Okay, so this is also mixed, right? So the gluten-free diet in adults with celiac disease, one study found that it may be associated with an improvement in thyroid function. Another one suggests that, hey, these diabetes and thyroid antibodies go away on a gluten-free diet for celiac disease. And another one then in 2012, they thought that, well, the gluten-free diet didn't alter the course of autoimmune thyroiditis in adults with celiac disease after only 1 year. But then the more recent study in 2018 thought that, hey, it doesn't reduce the risk of autoimmune thyroid disease in general if you've got celiac disease. And so again, the data is mixed, and like does a gluten-free diet for celiac disease improve autoimmune thyroid disease? The answer is like, maybe. I wish I had a better answer for you, but I'm not sure. But let's pay attention to this particular study done in 2008. It's a French study. I like this one because they were looking at autoimmunity before celiac disease diagnosis, but also after celiac disease diagnosis. So this top graph here looks at individuals who were diagnosed with celiac disease before 16 years of age, so in kids, right? And then this bottom graph looks at celiac disease that was diagnosed when you're older, okay, let's say adults. And like the blue bars represent the percentage of disease that's seen, or in this particular case, type 1 diabetes before they were diagnosed with celiac disease, compared to the red bars, which show the percentage of disease that was diagnosed afterwards. Okay, so in this situation, in the younger kids, right, you know, most of the diabetes that co-occurred with celiac disease was diagnosed before they got diagnosed with celiac disease, okay? And in fact, only about 1% of people with celiac disease here ended up developing diabetes afterwards, okay? And in this group, none of them had pre-existing thyroid autoimmunity, but they developed it afterwards. Not much, but it was there. And all these other kind of autoimmune diseases they looked at just occurred, both before and after, and to a much smaller degree. When you look at the older individuals who got diagnosed with celiac, again, diabetes occurred first, and then very few got diagnosed with diabetes after celiac. But then you're starting to see more individuals who already had pre-existing thyroid autoimmunity, and then someone that got diagnosed afterwards. But I think the bottom line here is that like type 1 diabetes and autoimmune thyroid disease really are the most common concurrent autoimmune diseases when you have celiac disease, right? In kids, it's important to note that the risk of type 1 diabetes to develop after celiac disease is about 1%. I think that's in line with a prior study from Sweden that suggests that the risk of diabetes after celiac disease was about 2.5-fold, which is about 1.5%. And the risk of autoimmune thyroid disease just simply increases with age. So this study also went on to look at like the effects of a gluten-free diet on autoimmunity, and they found that the cumulative risk of developing a new autoimmune disease after being diagnosed with celiac disease appeared to be lower if you actually stuck with the gluten-free diet. So these are the individuals months after the diagnosis of celiac disease. They were adherent to the gluten-free diet, and the risk of developing secondary autoimmune disease was lower than those individuals who weren't so good on the gluten-free diet. So this is really interesting. It's not the most definitive thing. We need really prospective clinical trials to know, but it certainly is kind of interesting and suggestive. Okay, the next thing I want to look at was really the special relationship between diabetes and type 1, between celiac disease and type 1 diabetes. All right. So the celiac disease major risk gene, like we said before, is DR3-DQ2. Okay, that's the heavy hitter here for celiac disease. In diabetes, the major one is having both DR3-DQ2 and DR4-DQ8. Okay, especially for early onset diabetes, like before age 5. It turns out that like probably about 50%, in the past, it was about 50% of all kids who developed early onset diabetes had DR3-DQ2 and DR4-DQ8, okay? Now with the environment changing, it seems like the contribution of this gene combination is actually less and less, which is another topic. But we can see that like, in people who have diabetes, it's like 5 to 10% of all individuals with diabetes will go on to develop celiac disease, okay? And so that's a lot, right? And this is why folks with diabetes are getting screened for celiac disease. Like at the Barbara Davis Center, it's every year they get screened for celiac disease. But the question is always like, well, what about the other way around? Why aren't we screening for diabetes in someone who has celiac disease? Well, the answer here partly is that, okay, well, the other way around is like 1 to 1.5%, okay? So it's a much smaller risk to develop diabetes if you have existing celiac disease. And we know that type 1 diabetes usually appears before celiac disease, okay? And so looking at the gene combinations, like having type 1 diabetes, okay, means you're more likely to have DR3-DQ2 and DR4-DQ8, which means you're already very permissive towards developing celiac disease. And this is not to mention all of these other shared smaller autoimmune genes out there. So this is data from the TEDdy study. And this is just to show you the co-occurrence of celiac disease and diabetes from the TEDdy study. So the TEDdy study follows thousands of kids who have a genetic risk, okay? They have DR3-DQ2 or DR4-DQ8 or a combination of both, 1 or 2 copies. Right? And so we follow these kids, and the families know that their children are at a higher risk of getting diabetes or celiac disease, okay? And as you follow them, some of them go on to develop diabetes, some of them go on to develop celiac disease, and some of them go on to develop both, right? And so this is the part that we're really interested in. I mean, like, so what's going on with these individuals that develop both? And the first thing I want to show you is like the incidence of diabetes autoantibodies, okay? Like when you look at this, it rises really sharply by 9 months of age. That's very, very early, okay? And then the incidence starts to decrease afterwards. And so when kids are gonna start diabetes, autoimmunity, it occurs very early in life, right? And then they start developing the diabetes afterwards. When you look at celiac disease, it also occurs early in life, but not as early as diabetes. The peak onset of celiac disease autoimmunity, okay, versus celiac disease is about 2 to 3 years of age. Okay, so yes, in general, the diabetes is actually probably occurring first for real, and then the celiac disease occurs afterwards. And it's just that the genes that they share are just very permissive for both. So we asked the question, does having celiac disease drive type 1 diabetes, or does type 1 diabetes drive the celiac disease? And like when we looked at the rates of having both diseases, okay, like that Venn diagram, that overlap, we looked at that, it was actually higher than what we would expect, okay? And so there were extra cases that co-occurred that we couldn't explain by accounting for like these extensive genetic factors or even demographic factors in TEDdy, okay? And because of that, it really does suggest that there might be like some shared environmental mechanism that could be contributing towards the co-occurrence of these diseases, okay? And I showed you like in early childhood, type 1 diabetes autoimmunity usually precedes celiac disease autoimmunity. And then the part that was really interesting in this study was that like having preceding diabetes autoimmunity really significantly increased the risk of subsequently developing celiac autoimmunity. So there's something about diabetes that actually drives celiac disease, but we couldn't really find it the other way around. There wasn't anything about celiac disease that we could find that was driving the diabetes. So, in summary here, when we ask the questions, right, does celiac disease directly lead to other types of autoimmune diseases? Well, I think the answer is kind of long. It's kind of like, well, yeah, there's a lot of genetic overlap between celiac and other autoimmune diseases. And by having these shared HLAs that we talked about, it's very permissive, right, towards the development of further autoimmunity, right? And the main diseases here are type 1 diabetes and thyroid autoimmunity, okay? Younger age at diagnosis, if you're diagnosed at a young age for celiac disease, that certainly is a risk factor for developing other autoimmune diseases, okay? It's just like having a family history of other autoimmunity promotes that. And maybe it's just if you get diagnosed with celiac disease younger, then you've got some more of an autoimmune drive, if you will. Now, we've also seen that the autoimmunity after celiac disease diagnosis overall is less common, okay, than before. But part of this may also be that these other autoimmune conditions just aren't as common in general as celiac disease, okay? And in general, I'd say that a delayed celiac disease diagnosis probably doesn't increase your risk of developing other autoimmunity. But it is associated with age, meaning I think it just means that being old just gives you more time to develop other autoimmunity, okay? And finally, there's something about having type 1 diabetes that may also be driving additional celiac disease autoimmunity. I mean, there's a lot that we don't understand here, right? But this is sort of my interpretation of the data. The second question, can the clinical course of autoimmunity be changed if a person's already diagnosed with celiac disease? And so the data suggests, okay, it's weak, but it suggests that the gluten-free diet in celiac disease may actually play a protective role against the development of other autoimmunity, especially thyroid autoimmunity, right? But what I'd say is that there's no evidence overall that a gluten-free diet prevents autoimmunity in general, okay? This data is really looking at it in relationship to celiac disease. So what should we be screening for then in terms of autoimmunity for celiac disease? Now, this is sort of my pediatric perspective, but I think the first thing to recognize is that the risk for co-occurrence of all associated autoimmunity is not equal. So when someone says, oh, I've got one autoimmune disease like celiac disease, therefore I'm at high risk of everything, I'm not sure that's true. I think we should try to be a little bit more specific about it. And I think a lot of this really depends on what other autoimmune diseases have that HLA predisposition, okay? And a lot of this, in terms of deciding screening, should be based on the frequency of the co-occurrence in celiac disease after diagnosis. And it should likely be age dependent, okay? And again, in pediatrics, we are screening routinely, periodically for autoimmune thyroid disease. We do, I think it makes sense to screen for liver disease periodically, and not just a diagnosis, but at least check the liver chemistries periodically. And one question that's always been in debate was, what do we do about diabetes? It's much less common, okay, but the impact of having undiagnosed diabetes and going into like diabetic ketoacidosis is profound, right? And there's been studies from the diabetes field that show that early screening, like mass screening for diabetes antibodies, and providing that education can actually reduce the morbidity and hospitalization rates and rates of DKA in people because they're already prepared for the risk. So even if we're not screening for diabetes in our patients with celiac disease, and I certainly wouldn't recommend checking at this point like diabetes antibodies, I do feel personally that we should be at least counseling for the risk of diabetes, and also to be looking out for teaching them how to look out for signs of high blood sugars. So that's sort of my take on it. I hope this has been helpful for you. This has been a really challenging topic, but I really do appreciate the opportunity to talk to you today.
Thank you so much, Ed. That was fantastic. A lot to think about. And we've gotten a lot of wonderful questions. Just for a heads up, there's far more questions than we can ever cover today. But please keep sending them in. The questions that we don't get to, we will be taking notes on, and we'll be considering those for further webinars in the future. So just because we don't get to your question doesn't mean that we won't be able to address it at a future talk. So thank you, Ed. We'll be calling you back for questions in just a little bit. But now I'm pleased to introduce Janice Arnold, who's a key member of our celiac community here in Boston. Janice is a clinical social worker and mental health clinician at the Celiac Disease Program in Boston Children's Hospital in Boston, Massachusetts. She provides psychosocial support to families and patients with celiac disease and other autoimmune conditions. Her published research includes the mental health aspects and impact of chronic illness on families, state and federal equity programs for effective advocacy for patients with chronic illness, school advocacy, educational equity, transitioning from pediatric to adult medical care, and the impact of chronic illness on patients' rights and medical coverage. She's a member of the Medical Advisory Board for the Celiac Kids Connection at Boston Children's Hospital, and presents to parents, sibling, and family groups, as well as regional and national conference audiences. So thank you so much for joining us, Janice. Really excited for your talk. And I think we are also going to start with a polling question. So we can go ahead and bring that up.
Great. While folks are answering that, I'll go ahead and start to share my screen.
So the polling question is this: for people with celiac disease and for their caregivers and community providers, what is, or do you imagine to be, the hardest part of managing celiac disease alongside an additional chronic autoimmune health demand? 1, loneliness; 2, lack of reliable information; 3, financial burden; or 4, loss of spontaneity. And I did hear that we seem to have taken the polling question down a little quickly last time, so we'll leave it up a little longer to give people a chance to respond. But I think this is also going to be really interesting to see where people fall on this.
Well, thank you so much for inviting me today. And I feel very honored to have an opportunity to talk with the community about kind of the other side of the coin of living and adjusting to celiac in addition to chronic health impairments. So what we're going to talk about today are the ABCs of living with CD or E and F, the ABCs being the adjustment and the balancing and the coping. And so this poll question is really to help get a sense of where some of the main pain points are for families, for caregivers helping their loved ones living with these chronic health conditions. So we see it distributed, certainly, and I think this loss of spontaneity is certainly consistent with some of the themes that I hear when I'm working with patients, and that kind of hard stop that so many of these conditions bring to getting through the day-to-day joys of life. And so that's what we're trying to kind of revisit and reinfuse for families. So thanks for your feedback. So to get started, I have no financial relationships to disclose. The objectives that we're going to go through today are to briefly describe the scope of the social work role in a medical care team for patients with celiac and other chronic autoimmune illnesses. It's a fairly new role to be embedded in a medical model. To identify the impact, the real reciprocal impact of the developmental life stages on adjusting to celiac and other chronic autoimmune conditions. and to start to recognize some approaches and some resources to manage the feelings and the burdens potentially associated with living with chronic autoimmune health impairments. So to start, when we're thinking about adaptation, we're really looking at everything that is at play for a patient and a family. And so that involves three very large spheres. And so we call this the biopsychosocial model. So the first is the psychological sphere, and this is a family or an individual psychological and emotional functioning as a family system, an individual set of temperaments that make up that family or that household, the level of motivation available to individual patients or family members or caregivers, and really what the problem-solving ability is already at baseline. And then we blend that with a social sphere, and that is the family's functioning over time and adjustment to things that get thrown their way. Social functioning, and this involves school or work or peer interactions, depending on the developmental stage of the patient impacted. This is where we think about the daily hassles that we all face and how those are managed day to day and how those tasks get broken down with various family members. The major life events that kind of punctuate a family's kind of lifespan. These might be important cultural events or developmental milestones or religious events. And then the social supports available to a family. And then we add in the biological, and this is really where we see the impact of chronic health impairments and autoimmune conditions come in. And the adaptation can vary based on the actual impact of the level of disease activity. And so we look at physical functioning. We look at what the actual diagnosis is. How much is known about that? Is it well researched? Is it fluent in normal conversation? How severe is the impact? And what is the visibility to others? We know celiac is one of many what we call invisible illnesses, and that can be for better or for worse for some of our patients. And then all of those come together to kind of create this nexus of what we're trying to promote, which is the well-being, health-related quality of life, and optimal adaptation. So why social work? Social work, the social worker in a medical model is really there to serve as a resource to normalize and honor what it would be like to have to inherit this new diagnosis and adjust in all of the ways that a new diagnosis of celiac or another additional autoimmune condition would impact a family or a patient. And so oftentimes there's a lot that can be done to help support and really help try to wrap our arms around a family. And there's not a need for kind of this more formal mental health role yet of this traditional billable therapy hour, but what we're trying to do is enhance all of the strengths to try to promote adaptation and not feel like we have to wait for there to be something very significant in terms of it. So often we are working to promote self-agency, helping parents find their voices with the medical team, figuring out who to go to for what. Connecting to community resources, those might be financial resources, those might be psychoeducational resources. To help assess for and respond to very real mental health, coping, or adjustment concerns, and these can vary at different developmental stages. To help problem solve barriers to a treatment plan, and these might be emotional barriers, a patient getting on board with a gluten-free diet or feeling like they're ready for a pump, a diabetes pump, or they might be financial barriers that prevent the treatment plan from being carried out. We serve to help advocate for a patient's needs on behalf of a family with a medical team. We often liaise and collaborate with other community providers. We have a lot of patients who are already working with behavioral health clinicians in the community for a pre-existing need and trying to help make sure that we're reconciling all the treatment plan goals so that they are aligned. Insurance barriers are very real. And so that's something that comes up, and we want to make sure that that's not a barrier to accessing ongoing care and follow-up, even when well and stable. School advocacy support is very big, from our littlest learners through college and graduate school, making sure folks have what they need to be as successful as they would be, helping access medications or the prescribed treatment. And we know for celiac that it is the major healthcare loophole in our country. There is no coverage for our established prescribed treatment. And so that is a big part of making sure that that is not an impediment to being as healthy as possible. Problem solving ways to maybe motivate or engage a patient. Maybe we have dissonance between caregivers and the patient, him or herself or their self. Outpatient therapy referrals, if we are identifying that kind of a more standard traditional therapy model would be a helpful augmented support, and we can do that. And we often do that. We find that maybe parents need help going through some of these diagnostic stages. Mutual aid connections, making sure folks have their villages of other folks who understand this, whether it's a parent, a caregiver, another community therapist, treating some of these themes. And really just navigating and supporting health related to the autoimmune conditions through all of life's transitions, jobs, schools, households. And in that prior slide, when we think about those three spheres, as a social worker, we really want to help incorporate that biological sphere, the medical needs, into all of the non-medical considerations in someone's life. So what is the impact of multiple health conditions? And this is really just meant to kind of affirm and honor what it can feel like for a family or a patient to get new diagnoses, and maybe one on top of another within a household or one on top of another within a patient. There are shattered assumptions and vulnerability that might be new. There is loss, often loss of control, loss of the anticipated parenthood, if it's a caregiver, or even if it's the parent who has these diagnoses, loss of the anticipated childhood, loss of the anticipated lifestyle. This is where we see the loss of spontaneity really impact joy, and just loss of kind of family movement and the family dynamics needing to be redistributed. We have uncertainty, we have unpredictability. We have these vertexes of stress that can come at the time of a new diagnosis or even a new treatment decision, complications, school and work reentry, new developmental stages, and any decision that's really being asked of a family. There can often be a disconcordance with what we know are the developmental tasks that we would want to help a patient go through depending on their age, and some of what the treatment plan requires is really very different than what we would be hoping would be accomplished during those developmental tasks. We know that a lot of these conditions insist on dependence when what we're trying to do is nurture independence as time goes on with our patients and families. There's standard developmental milestones that could be impacted depending on the burden, the medical burden and demands, the isolation, which might be elective or might be not elective. When I think about celiac and chronic autoimmune conditions, I think about the topography of it and how that impacts families. And so oftentimes we make a diagnosis, our team makes a diagnosis, and we think, okay, well, here's your treatment plan. We are on a path, we have an answer, and we have a path forward. And so we think that this is the plan. And in reality, it is fraught with potholes because there are new stressors or new developmental stages or things that had not been anticipated or unanswered medical questions and undone research. And when I work with patients, we often talk about it being a little bit like the switchbacks of a mountain, that, there's no direct path up to the top of a mountain. To hike a mountain, you're often doing miles of switchbacks and you're exhausted. You feel like you've been working for days and you've gone half a mile, but you are making progress. I think what's different for our patients with chronic autoimmune health impairments is that there's not really a top of the mountain, and we want to honor that these switchbacks continue to go on. A lot of folks have heard of Kubler-Ross from a grief cycle model, but not as many folks are as familiar with her change curve model. And this really speaks to what someone can encounter, not necessarily, but can encounter when there's a significant life change. And I think we'd all agree that a diagnosis of celiac for anyone we love or take care of or are ourselves is a significant life change. And then if you were to add on top of that an additional chronic health condition, even to the same family member or to the household, it can compound. And so the idea behind this change curve is that we are looking at where we can mobilize resources to promote health maintenance, to promote engagement, to promote active participation. And so wanting to move folks, figuring out where we're doing that experimenting and where we're doing the decisive decision-making and integrating. When we have chronic health issues like celiac, where there could be an exposure, an unknown exposure, this change curve doesn't just stop at this kind of discrete square that we're seeing. And it can continue to repeat itself. And sometimes the dips are more frequent because there is a new exposure or a new diagnosis or a new health concern. Or just a new family struggle and coping with it. And so, it's this kind of chronic sorrow that we want to try to mobilize families out of and recognize where they might be sitting in this change curve and how to move to the next section. We know that we are all individuals that go through developmental life stages. And so when we think about medical conditions and the health demands, specifically for celiac, but in addition to any other chronic condition, there is a reciprocal relationship with the developmental tasks in this framework. And so it could be that a diagnosis is given at one point and is adjusted to and integrated beautifully, and then the patient hits a different developmental stage, and suddenly there's new issues because there's an interruption with the task. So this is just kind of a rudimentary breakdown of the developmental stages. And you'll see on the left, we have these different stages, and then the tasks that are really associated with what we're expected to master, kind of subtly, but inherently as we move through these stages. And so then you see where on the right, there would be an impact on some of these cornerstone tasks if health demands interfere substantially, if there is a destabilization during these developmental stages. And this doesn't mean that they can't be reclaimed and that they're not reclaimed, but just be aware of where we can start to intervene when we're looking at actually balancing the needs of family members and coping with what feels like it's been lost. So as an infant, bonding is one of the primary issues if it's a caregiver who's been diagnosed and managing a chronic health impairment. A toddler we know is seeking control, and so that loss of control through multiple medical, potentially invasive medical encounters kind of threatens their sense of autonomy, learning that they are not just an appendage of their parent. The preschool age early on is where we're looking to foster initiative, and so we see separation and regression sometimes there if there's a loss of being able to choose what you'd like to eat, or not having a say in the amount of lab work that you're experiencing. The school age is where we're looking at industry and socialization. And I think we can all appreciate where that would be interrupted if there's constant doctor's visits, if there's inability to feel well enough to participate socially in invitations. And those peer relationships and the mastery over those social skills can sometimes be a little bit interrupted. Adolescence and young adulthood is where we're really looking at identity formation and independence. And this is where we sometimes see the disconcordance. And we're looking at the impact on body image, which is very important at this age, obviously, and intimacy, which is not just physical intimacy, it's really emotional intimacy and friendships and stronger partnerships, and the ability to feel that there's been achievement met as you go through young adulthood. In adulthood, we have this task of generativity, and this really refers to this concept of making our mark in mid-adulthood. And so if there's recurrent health demands that continue to interrupt this, then we have potential stagnation and isolation. And then in later adulthood, we have this task of ego integrity, which really speaks to feeling that we have this one and only life cycle, and we have a sense of cohesiveness and wholeness in how we've lived it. And this is where we can sometimes see some despair and regret, depending on how much the medical condition has impacted our daily life. So if we were to break this down just a little bit more, when we look at the preschool age, at this age, there's not really the understanding of why a parent wouldn't protect them from a procedure or a blood draw. And so being mindful of the extra explanation it might take to have a preschooler kind of trust the process. We see magical thinking and associative logic, things that aren't connected. Did I get diagnosed with celiac because I was mean to my mom yesterday, or I didn't listen and clean my toys up? And so wanting to really assess for this and make sure we're dispelling any of those myths. We have a very concrete thought process, so we need really concrete education on what celiac is, what it isn't, what we're asking someone to do. And this is where we sometimes see the kids kind of attribute events to a feeling that they might have had. And they have this very causal link between physical and a temporal proximity, and they don't under time needing to really do some clear explanations around decisions that are being made and why it's in their best interest. We know that the school age task is mastery, and so we have wonderful advances in cognitive skills at this age, but what that does is it sensitizes patients to new aspects of encounters that they might have previously felt really comfortable with. And we see the emergence of kind of this fear of bodily harm. This is the age where maybe someone who's constantly going to get lab draws to have their TTG rechecked is starting to now battle that, because they are worried that the puncture point of the needle means that there will be a hole in their body and all of their blood will pour out. And so something that might have felt integrated before, it can start to feel more difficult now because of the new cognitive skills. We have a loss of control if any of these encounters kind of challenge their basic need to kind of master an environment. And so this often comes out as anxiety, and it's something that we want to continuously assess for. And language can be confusing at this age, even the word shot, depending on somebody's community. If shot means more than one thing, or often we'll use the word funny, this might feel a little funny when in fact something doesn't feel funny, it feels painful, and wanting to be mindful of how language impacts coping. In adolescence, this is where we see that if adolescents are really dependent on their parents for every meal, for all of the things that are in the house because they can't be spontaneous, then it can lead to resistance, and that can come out as non-adherence. We know that non-adherence is really a communication, and so we need to figure out what that's trying to communicate. It's often appearing to sabotage treatment, and we get those frustrated calls from parents, and it comes down to figuring out what they're trying to tell us with their difficulty adhering. And here is the stage where cognitive advances are an asset. They allow for tremendous abstract coping gains, but they can sometimes be a liability, because this is where we start to see some of the greater resentment for the loss of spontaneity. And then moving into young adulthood through later adulthood, we have these tasks of launching and really feeling like there's the ability to have enough of a handle on your medical condition to set up your own roots, wherever those must be, and forming your own identity. Young adulthood is often time to rebrand yourself and figuring out where your medical conditions live in your identity. And we see interruption to career and work consistency in mid-adulthood, depending on the amount of medical demands that are levied, and that it can impact caretaking roles and lead to redistribution of kind of family roles. And in later adulthood, we see an interruption to reflection. We see an increase in dissatisfaction and concerns about not being able to do as much memory making if there's just constant medical demands that take someone out of a family system or structure. In addition to individual stages of development, there are family stages of development. Rhodes is one of the most well-established, and I do want to just take a moment to honor that number 1 and number 4 are not required, and I think we all know that this is a bit of a dated framework, but I highlighted the 3 that are most important. We know we don't need to have a strong partnership to have a family, and that is not the root of a family. But if that is at play, then that is often the first stage. But really the nurturance of individual family members and then the individuation of members happens so that we can prepare for essentially this launching task, this regrouping to maintain a healthy departure. And so if someone is growing up with celiac and constantly relying on others and has another health condition on top of that, one of a number, it can kind of interrupt and suspend the sense of being able to achieve the safe and healthy departure. And so you have this alongside the parallel process of the individual developmental tasks. So let's move a little bit to coping. So what do we do about all of this? Well, automatically, without thinking about it, multiple times a day, we are faced with scenarios where we make our stress appraisals. And there is a primary appraisal and there is a secondary appraisal. And we do this without thinking usually. A primary appraisal is saying, is this important to me? Is it relevant to me? Will it pose a threat? Will it cause harm? Will it present a challenge? The almost immediate secondary appraisal is, do I have the necessary resources to respond to it? And we do this so often that we don't break these down usually. So if the answer to the primary appraisal is no, this isn't important to me, then the answer to the secondary appraisal often doesn't matter. If the answer to the primary appraisal is yes, this is important to me, and the answer to the secondary appraisal is yes, I do have the resources, then we sometimes have less of a stress response and coping feels a little bit more managed. The trouble comes when the answer to the first question is yes, and the answer to the second question is no. And when we think about necessary resources, these range. Often it's just time. Do I have the time to manage what is going to be involved in raising my child with celiac, or doing all of the research, or understanding all of the labeling laws? Do I have the money to afford this food? Do I have the money to afford the copays, the gas to the appointments? Do I understand what they're saying? Do I possess the health literacy level to understand what's being explained to me? Can I manage pain? Do I have a high pain tolerance? And then really, do I have the village I need? Do I have these concentric rings of support to get me through? So what are some resources to help secondary appraisal? We've answered yes, that loving someone, raising someone, being someone with celiac or another autoimmune condition is important and relevant. How do we help the secondary appraisal? If time is the issue, sometimes helping a family pursue Family Medical Leave Act paperwork as a caregiver or as a patient is helpful. It maintains job security, gives time off, maintains benefits. It does not maintain payment, but sometimes it gives enough of a cushion to feel like you can take a breath when needed, and it doesn't need to be used continuously. And just the diagnosis alone of a chronic health condition does qualify someone. Social Security disability insurance, it is not universally applicable for all diagnoses. For example, celiac alone does not qualify someone, but if you have celiac and diabetes, usually there is a pathway to being able to get this. And so it is a process, and it's a lot of paperwork, but sometimes that extra income, which is not a privilege, it's not, you're not asking for extra. This is something that you'd be entitled to because of medical conditions beyond your control, can help feel like you can have a handle on what's facing you and what the actual financial burden might be. There are multiple grants for medically associated costs. These are a few: the United Healthcare Children's Foundation, the Healthwell Pediatric Assistance Fund, Claire Bear Foundation, the Patient Network Foundation, and all of these help kind of supplement very specific medical needs. There are free medications for the underinsured. This doesn't mean that you don't have insurance, but as we know, if something is chronic, the cost of the medications doesn't go away. So Needy Meds has an entire clearinghouse that lists every medication, generic or name brand, that has a patient assistance program. And that's something that a patient could apply for and get free medications often shipped to the house. And then mutual aid villages. And this is back to those concentric rings of, do I have what I need? The National Organization of Rare Diseases is a phenomenal organization. It doesn't actually require that someone have a rare disease, but sometimes the combination together would qualify someone to receive services. And then the American Autoimmune Related Disease Association and the National Coalition of Autoimmune Patient Support Groups. So what do we do to actually cope? We often need to be both in the forest and the treehouse. We need to take steps up and sometimes not go all the way up, and then go immediately back down and jump in. And so when I think about this, I think of the physiologic stress response. It's often like a seesaw. We cannot be physically tense and stressed and relaxed in our mind at the same time. They are mutually exclusive. So any amount that we can intervene physiologically to dampen the stress response, our seesaw kind of has to follow. So this is mindfulness, this is relaxation strategies, and this is an effort to give the body time longer to get through a stressor. These are techniques that have been shown to be very helpful in coping and treatment for chronic health impairments. Cognitive behavioral therapy looks at the interplay between thoughts, behaviors, and emotions. And so if I have a thought, I'm going to go to this party and no one's going to understand my food restrictions. My behaviors, I'm not going to go to this party, and my emotion is that I'm lonely. We're looking to intervene on any one of those to change the other two. We're looking to combat cognitive distortions. And so blue thinking is a really good way to think about whether or not we're falling into thinking traps. Are we blaming? Are we looking for bad news? Are we making some unhappy guessing without data? And are we exaggerating and imagining a worse outcome? Diffusion is a technique that comes from ACT, acceptance and commitment therapy, which is another really well established treatment for these set of chronic health impairments and celiac. And we're looking at cognitive flexibility here, just a chance to diffuse and detach so that we are not defined by these thoughts we're having. And so if you were to come up with a thought, I will never feel healthy again, for example, and you were to just say, I'm having a thought that I will never feel healthy again. I am noticing that I am having a thought that I will never feel healthy again. I am aware that I am noticing that I am having a thought that I will never feel healthy again. We start to see how we can detach a little bit and kind of subtly change our relationships to our thoughts. Get off your butts is a good one to remember. This is where we just start to replace all uses of but with and, so that we can appreciate that this small cognitive shift, that we can take action without needing to eliminate a feeling that we're having, or rather than fighting the feeling, that we can have the feeling and we can still act. So I want to go to the birthday dinner, but I am too anxious. I want to go to the birthday dinner and I am too anxious. We can honor both of these simultaneously and be more likely to go towards an action plan. Metaphors are used around the world, and they're a great way to change perspective. When we're feeling anxious about an exposure or a new experience, then compartmentalizing can be helpful. And this is really just taking that worry and imagining that you have a refrigerator and putting it in that refrigerator, and you're storing it and you're keeping it safe and you're keeping it fresh. And when you open that door, we will shine a light on it again. We are affirming that it's a valid way to feel. And we're not looking to eliminate it. And so sometimes knowing it has a place to live when there's not forward or you want to move on can be helpful. The online shopping metaphor is helpful. It's nice to remember to not lean into feelings that are not going to be productive to us. So if we were to go online and go shopping, we don't control the initial inventory. But if I were to go online and buy a lot of staplers, then eventually that store is going to say, there's a huge demand for staplers. I should keep stocking staplers. That's what she wants. And if we continue to say, I'm going to lean into these anxious thoughts and I'm going to continue to isolate, then those are the thoughts that are going to be more readily available, because there's the assumption, your brain is going to think that that's what you want more of. That'll become the default. The guest house is a chance to think about honoring all of these various versions of yourself as welcoming them into a guest house, so that you're not defined, a patient is not defined by any one feeling of discouragement, and you can kind of honor all of the different yous that come with living with these medical conditions. And so there might be the feisty you, there might be the discouraged you, there might be the resilient you, there might be the in pain you, there might be the fearful you, and that we welcome them into the guest house and we let them stay, but they are simply guests and they are not our identity. The computer pop-up is one that I like to use with teenagers just to get a handle on not worrying about the worry. And so sometimes treating the worry as a computer pop-up. We all work on computers, we get the pop-up. We cannot minimize that pop-up until we honor it and see it and acknowledge it. So we're trying not to be in denial. We name it, we see it, and then we minimize it. And when we minimize the computer pop-up, we don't spend the time in between pop-ups worrying about the next pop-up, but we know it'll come. At some point, it will ambush whatever we're doing. And so starting to think about treating anxiety in that same way. So really it comes down to, preparation, anticipation, and communication. We want to listen to the strengths that are already there for a family and for a patient and where the vulnerabilities are in that kind of psychosocial wheel. We want to help you build your village and know not everybody's the same role in your concentric rings of your village. Mutual aid is so important, especially with celiac, which is one of the only conditions where the treatment plan is virtually the same for almost everyone. Anticipatory guidance allows for actual concrete problem solving. So helping families anticipate another developmental stage or a new experience or the first time someone's gone to summer camp or the first family vacation after a diagnosis. Reframing, which is what some of those metaphors help do, and normalizing, which then lets us honor that these are real feelings that deserve time and we don't want to dismiss them. Developing short and long-term goals and action plans so that it feels like there is still momentum. So I think in conclusion, we want to help encourage finding meaning along the way. There's hard work being done and there is tremendous gains being made at each step of living with a chronic health condition. There is the honor of bearing witness, and that might be as a caregiver, just watching someone go through this and helping encourage them and not underestimating that connection. Figuring out what can be left and what can be carried. Where can we compartmentalize? Where can we bring with us to the next stages the things that worked in the prior stages, that Kubler-Ross life cycle and life change cycle? Having self-compassion, partnering with the medical team, and really trusting the scaffolding that all of the education, all of the learning that's been done doesn't break down. There might be a brick that falls, there might be mortar that gets wet, but the scaffolding stays up, and to trust that in a family and in a patient. So these are just some final thoughts and a number of resources that were mentioned in earlier slides, but are just broken down a little bit more in terms of what they can offer and the contact information. And then these are some apps if the mindfulness and physiologic stress response is something that you or a loved one has noticed, and these are ones that we would recommend contact. Thanks for your attention.
Thank you so much, Janice. That was fantastic. So I'd invite Ed to come back on, camera and mic, and we'll go through as many questions as we have. We've got about 10 minutes. So Ed, why don't we start with you? There was a question, there's been a couple questions about the difference between celiac disease and celiac disease autoimmunity. And related to that, what what are the current diagnostic recommendations? Do we always need endoscopy, and especially for COVID, for adults and kids? Has this been changing? What are you recommending?
Okay, yeah, maybe I could have been more clear about that from the beginning, so I apologize. So celiac disease autoimmunity, that's sort of like the term we use when someone has antibodies, like celiac disease antibodies. Now, I think it's important to recognize that just because someone has antibodies, it doesn't mean that they automatically have celiac disease, okay? And so this is especially relevant when we're looking, for example, like in the TEDdy population, children who have a genetic risk for celiac disease. We test them every year or even more frequently for celiac disease antibodies. And when the antibodies are positive, it doesn't necessarily mean that they have celiac disease. We need to go on to prove it, right? We need to go on and get biopsies or things like that. And sometimes just having antibodies, sometimes having antibodies basically tells you that there's an autoimmune process that's going on. And that's what it means to have celiac disease autoimmunity. And if you have celiac disease, you also have autoimmunity, but you also have celiac disease. And so it's just sort of like the earlier stage before someone develops celiac disease. And it's important to note that sometimes people, in kids that we follow, they can have antibodies that just go away on their own. And that's why having antibodies doesn't automatically mean you have celiac disease. Now, I guess the second part of the question, in terms of criteria, this is why we can't just rely on antibody testing like TTG, transglutaminase antibodies, to say someone has celiac disease. Now, in the time of COVID, we've had to sort of adapt to the times where we can't always get an endoscopy to diagnose someone. And when a child's found to have antibodies, I think they want to find out really quickly whether or not they actually have celiac disease. And so we've started to adopt the European criteria for making the diagnosis of celiac disease based just on serologic diagnosis. And so there are ways to make a diagnosis where, for example, someone can have, if you have very, very high levels of TTG antibodies, meaning 10 times greater than the cutoff, and you have the secondary celiac disease antibody called the endomycelial antibody test, the EMA. And if that's positive, that's enough in pediatrics, according to the European criteria, to make the diagnosis of celiac disease. I think in general, though, for North America, we still want to try to use biopsy-proven celiac disease. And this certainly shouldn't be automatically applied to adults, but it's sort of been our backup that we use because of the pandemic.
Great, thank you. So next question for Janice. Talking about kids with multiple autoimmune disorders, especially things like celiac disease and diabetes, there seems to be, it's a challenge to maintain both a healthy diet and a healthy relationship with food. And how do you navigate that? What advice would you have for parents?
I would just applaud that parents are even thinking about that ahead of needing to kind of come in a crisis situation. I think a lot has to do with language. And we, in our society, we've become accustomed to using words like good or bad. That's good for you, that's bad for you. And we're essentially assigning kind of morality to food. And we know that no food is good or bad. It is our encounter with it, and our medical condition might impact our encounter with it. And so I think being mindful of the language that is being used to discuss the foods that are even options when there are legitimate restrictions. So coming back to some of the language of what food is meant to be, it's meant to nurture and fuel you. And so this is not going to be the right type of fuel for you, or this is not going to be a safe type of fuel for you, rather than good or bad, because that does become kind of a dichotomous way of thinking about food, and that's what we want to avoid. I think involving patients or growing children in the decisions as much as possible, cooking together, having them when a pandemic would allow, go to the grocery store together and pick out things that they are excited about. We find that kids are innately excited about food, so we need to just resurrect that as quickly as possible and get them excited about what they're going to eat. Not have them see all the things they're not going to eat on a regular basis, and then also make sure that the language we're using to talk about something that we might not be able to offer them doesn't assign that food a judgment, that these are really just categories.
Great, thank you. So next question for Ed. Again, there was some questions about the relationship between celiac disease and neurologic dysfunction, and most specifically, there was a few around autonomic nervous system dysfunction or POTS syndrome, postural orthostatic syndrome? Are these autoimmune? Are these related? How do you think about these conditions?
Yeah, I didn't want to talk about autoimmune, or sorry, autonomic dysfunction, because there'd be too many autos in my talk. But it's a good question. I think it's sort of been like a growing interest, right, in dysautonomia, autonomic dysfunction, POTS, which stands for like postural orthostatic tachycardia syndrome. I mean, and this is basically a condition where, like, especially in teenagers, in adults, like, you're dizzy when you stand up, right? You get fatigue, you get headaches, I mean, you get all these other kind of things. And people feel legitimately terrible when they have this kind of orthostatic intolerance. They get dizzy. It's associated with like a lot of GI symptoms as well. And so there's one paper actually that suggests that there's a relationship, for example, between like people with celiac disease and this underlying condition called Ehlers-Danlos syndrome. It's a connective tissue disorder, one that suggests it. But I think, in general, like these things are both becoming more common, that they sort of overlap that way. But the reason why I talk about Ehlers-Danlos syndrome is because a lot of these folks end up having dysautonomia and POTS, okay? But having said that, like, like when you have like over like 300 different kinds of symptoms that are reported to be associated with celiac disease, a lot of this, is related to having like POTS, okay? And so I guess what I say is, yes, these things can overlap, but a lot of times when someone has celiac disease that's like poorly managed or out of control, it basically drains your battery. And then like when that happens, then you end up having more dizziness and all those other kind of symptoms. Now with this whole spectrum, I mean, it's a whole different kind of topic, okay? But there is probably some overlap between having autonomic dysfunction and POTS and celiac disease, but mostly because when you're just not feeling well, it leads to this kind of stuff, like POTS and dysautonomia. Now, is there an autoimmune link to this? It's hard to say. I think that in this field of people with dysautonomia, there's a lot of thought that, like, yes, you're more likely to have Sjogren's syndrome, you're more likely to have antiphospholipid syndrome, and all these other kind of things. And it's not really clear right now whether or not there's truly a link. But in times where individuals are desperate for some sort of treatment for their profound symptoms, we oftentimes do look for autoimmune causes. And that has at times led to like more extreme treatment, for presumed autoimmunity. And we have to be careful of that. But at the same time, when individuals are really struggling, sometimes you do have to think outside the box. So bottom line is, we don't really know enough yet about it, but there is a lot of thought that there is an autoimmune basis to dysautonomia, in some cases, in other cases not. I hope that answers your question. It's a whole different topic though.
Yeah, and again, maybe a whole talk for a different time. So Janice, one question that I think you made a great argument for the value of social work in people with these multiple disorders, or even one. How do you find a social worker, especially if you're outside of the Boston area, and how do you find one specifically who is knowledgeable about multiple autoimmune disorders?
It's a great question. And I'm hoping that, even in the next 10 years, you're going to see many more kind of community embedded social workers. It's really grown even in the last 10 years. If your care is affiliated with a major medical center, then there is likely a social worker that is kind of dedicated to a GI center or department, even if not fully and solely embedded. And so that would be one place to start if your care is there. Otherwise, there's a resource that I even might have been mentioned in a prior webinar called Psychology Today. It's called Find a Therapist. And we often use that to even get us started. We're trying to help link somebody in a town we're not familiar with. And you can search that tool based on chronic illness. And many other things: insurance coverage, telehealth availability, age preference, experience with motivational interviewing, depression, anxiety, a number of issues, and kind of get a sense of how, through their profiles, of how much chronic illness work they do. My experience is that those clinicians who identify chronic illness have tremendous experience working previously before going into private practice in healthcare settings. And they might be psychologists, they might be social workers. And what I would suggest is then, when you have an intake, is to specifically ask about your specific conditions, or the ones that are in question, to see if they've ever had patients with those. My experience is that any good social worker or mental health clinician can learn about any condition through liaising with a medical team. It's really the experience of the narrative of living with a chronic health impairment that we want to capture when you're looking for someone to work continuously with.
Thank you. So unfortunately, we're out of time for questions. I know I would love to continue this on for another hour, but we will have to take a break. But thank you again so much, Dr. Liu and Janice, for these wonderful presentations. Thank you to the Harvard Celiac Disease Research Program and to the National Celiac Association for organizing this talk. And with that, it's been a pleasure to be the moderator, and I'll hand it back to Lee for some closing remarks. Thank you all.
Thank you, Dr. Leffler. I think even though I've lived with CD for decades, there's so much I can learn. And I hope today that you all found this information as useful as I did. Thank you to our speakers. They were just wonderful. As we mentioned before, recording of today's webinar will be on the National Celiac website, probably in the next 7 days. It doesn't come on immediately. Meanwhile, I hope you will join us for our next webinar, which is Thursday, March 25th at 1 o'clock Eastern Standard Time. It's called Get the Facts on the COVID-19 Vaccine and Celiac Disease. So I'm hoping you will join us. And in the meantime, stay well. Look forward to seeing you next month. Bye-bye.
Thank you.
Thank you so much.